So our new slogan when we say the NICVD, the largest cardiac network in the world, I think it's time from focusing more from volume to the quality of the program, as Dr. Nadeem just said about the VSD. I think this is a great effort towards that goal. We have to be known for quality. We have to be known for education and research. And I really commend Dr. Abdul Hakim and Dr. Jahangir and all of you for this effort. So I'll talk about peripheral arterial disease. Usually I'm used to give 5 to 6 minute short talks to the point, but this content will be there forever, so I want to cover as much as I can in about 20 minutes. So there will be a lot of slides that I will be skipping through. I have no disclosures. So let's start off with this case. This was a 67-year-old lady with a history of tobacco abuse, 100-pack year history, and she underwent a limited right bunion surgery, which is a very minor surgery, but then she presented a few months later with this. And her ABI was 0.8, which is pretty much normal. Normal ABI should be 0.9 and above. So she was recommended amputation, right? And this is what the knee-jerk response is. So Dr. Craig Walker has been my mentor. It's one of his saying is that for some reason it is considered a conservative treatment to chop someone's leg off and aggressive treatment to even perform a simple angiogram. And this is backed by a Medicare data where about 50% of patients who undergo amputation, they don't even get basic angiogram. But in this case, what we did, we performed an angiogram. Again, I skipped the ultrasound, non-invasive, just looking at the patient, the history, the pulses. We went for angiogram, and there was a complete occlusion of the SFA and POP. Went in and crossed the lesion, did a drug-coated balloon, and we got a good flow all the way down, three vessel runoff. And it's the same patient after a couple of weeks with aggressive wound care therapy. She went on to heal wound without amputation. Again, amputation is not just chopping someone's leg off. It really affects the quality of life. The patient is not the same anymore. So when we look at the amputation rate, it's pretty high in the US. And in patients who have amputation with critical limb ischemia, their 5-year mortality is, if you look at these numbers, it's worse than colon cancer and breast cancer. And we talk about these cancers, but we never talk about critical limb ischemia. So the mortality in these patients are pretty high. And why is that? Because PAD is one of the cardinal manifestations of a systemic atherosclerosis. I mean, CLI does not just happen in isolation. It is one of the part of the CAD or the cerebrovascular disease. So it is the presence of stenosis or occlusion in the aorta or arteries of the limbs. And if you look at the prevalence, it's pretty high prevalence. If you are age, more than 50 with diabetes or smoking, the incidence can be as high as 30%. So it's fairly common. It's just that we don't look for it. I mean, if you don't look for it in the US, you can imagine what we do here in Pakistan. Again, if you look at the survival in these patients, compare that to normal patient, it's pretty miserable. Even patients who are asymptomatic PAD, who does not have any leg pain or critical limb ischemia, but if their ABI is abnormal, their mortality is worse than patients who have normal ABIs. So the PAD severity, if you look at the symptomatic spectrum of PAD, it goes all the way from asymptomatic patients, about 20 to 50%. About 50% of the patients will have claudication. When they have pain in the leg when they walk, when they rest, the pain goes away, or the buttock pain if they have distal aortic occlusion. About 1 to 2% of these patients will have critical limb ischemia, which is ischemic rest pain, minor tissue loss, or major tissue loss. Although critical limb ischemia accounts for only 1 to 2% of overall PAD spectrum, but in these patients, if you don't intervene, these patients will lose their limbs or ultimately their lives. And again, looking at critical limb ischemia, not the overall PAD, if you look at the critical limb ischemia, those at 2 years, those who are alive with 2 limbs, it's about 50%. Amputation risk is 25%. Cardiovascular mortality is 25%. There's no other disease that I know of where the mortality in 2 years is about 25%. Again, these patients with leg pain or wound, they don't die of amputation. They die of heart attacks. They die of strokes. So what should we do in these patients? I mean, these patients, whenever I see a patient with wounds in their legs or severe pain, I ask them about their heart first. You have to assess them for any typical or atypical chest pain. These patients need complete overhaul of their lifestyle, tobacco cessation counseling, diabetes control. Hypertension control really helps these patients. Even use of antiplatelets improves, have about 32% reduction in their CV events. Lipid control statin therapy not only improves their odds of healing their wounds, it also improves their walking distance and also improves their mortality. So these simple things in these patients matter. And these patients need to be referred promptly to podiatrists or wound care specialists. When you see this patient in your patient, always take their socks off, their shoes off. This is something we never do. I mean, you have to be carefully examining their legs if they have thin, dry, shiny, hairless skin, or in these patients with CLI, their nails may become brittle, hypertrophic, rigid, and they have cooler extremities. And if you see here, this is called dependent rhubarb. This dependent rhubarb, this is an ominous sign. If you don't intervene, these patients will lose their limbs. Let's talk about some testing. ABI is a great test to determine the presence of disease. It's inexpensive, it's widely available. However, it's difficult to perform in the setting of limb wounds or ischemia. Like we saw in our patient earlier, her ABI was 0.8. And if someone has a lot of calcification, you can get normal or above normal ABI numbers. So don't rest your head on ABI only. Not only calcification can give you false elevations, it also does not take into account the angiosome concept. I mean, from the heart, we know that the RCA supplies the inferior wall, LAD, anterior, circumflex lateral. The same goes for the legs. There are certain areas in the legs supplied by anterior tibial or posterior tibial or peroneal. So the ABI just take into account, like in this patient, if we do the ABI in the posterior tibial, you may get normal ABI, but the problem is the anterior tibial artery. You can see here the anterior tibial artery, and this is where the angiosome is. It supplies the dorsum of the foot. So you have to have a straight line of blood flow all the way to the base of the ulcer. TBI, which is a toe brachial index, is a better test than the ABI. It's not affected by the calcium because all those small arterioles in the toe does not have calcification. And the absolute pressure of more than 30 is favorable for wound healing. Then we have segmental pressure, which demonstrates the level of arterial disease, however difficult to perform in the setting of lymph wound or ischemia. The TCPO2 gives us supplemental info about the local tissue perfusion or assess the healing potential. Not widely available, but this is a good tool to have in your lab as well. Now, going on to the non-invasive imaging, the ultrasound, it accurately assesses the arterial anatomy. It also gives hemodynamic information. It's heavily tech-dependent, and it does not really assess more proximal vessels, like, for example, iliac arteries. CTA, CT angiogram, it can accurately assess the arterial anatomy. However, it is associated with contrast load. And it does not really opacify below the knee vessel if they are calcified. I mean, this is the problem that we see with the CTA. The MRA is better test than CTA. But again, the availability is the issue. It's not available, and it is expensive. And the contrast we use can also be associated with nephrogenic systemic sclerosis. Hagiography is the gold standard. It also allows for immediate intervention. Again, the problem is it is invasive. We also use contrast, but the good thing is about hagiography is that if you don't want to use contrast in someone with CKD, we can always use carbon dioxide. So again, talking about critical limb ischemia, it's usually a multi-level disease, but it affects both above the knee, below the knee. But once you have Rutherford classification 4, 5, and above, which is the wounds, it's usually below the knee disease. And if you have Rutherford class 2, it is usually above the knee disease. Talking about the intervention, the standard of care nowadays in the CLI is either endovascular intervention or surgical intervention. Now, which one is better? It is debatable, depends on who you ask. If you look at the endovascular compared to what we were about 10, 15 years ago with the new technologies coming in, the drug-eluting stent, the drug-eluting balloons, the patency is comparable to surgical bypasses. And this is the Boston Alluvia stent. We're comparing the drug-eluting stent versus bare metal stents. It has excellent patency at 1, 2, and 3 years. The same goes for drug-coated balloon. Now, this was a randomized controlled trial, a French study. It's called the TECO trial. It was comparing directly stenting versus common femoral artery and aortectomy. And in this study, what we saw was the primary outcome, which was the composite of morbidity and mortality 30 days, occurred in 26% of surgery group, compared to 12% in the stenting group. So the stenting group did better, but this outcome was mostly driven by the wound infections, lymphoria, or paresthesia right after surgery. And the patency was similar at 2 years. So in France, I mean, even for common femoral artery, where we say it's a no stent zone, and in France or in Europe, that's where they are going towards stenting. But in the US, that trend has not caught up yet. This was another study which was published about 2 to 3 months ago. I think it was a month ago. It was the best CLI. It was surgery versus endovascular therapy for chronic limb-threatening ischemia. In short, the bypasses, if you have a good vein bypass, they had 32% reduction in major adverse limb events or death compared to endo. So here they said the surgery is better. But if you look at the detail of this trial, I mean, the failed endovascular therapy was about 20%, and most of those were performed by the surgeons. So again, it is kind of debatable. So let's look at the guidelines, what the guidelines says now. To be like very precise, not going further into a lot of trials. Basically for FEMPOP disease, if you look at all the greens, grade 1 recommendation is for either drug-eluting stent or drug-coated balloon. I mean, I see we still use a lot of just plain angioplasty in the SFA popliteal, but the rates of restenosis is very high. And the only therapy that I can see, the laser atherectomy as a primary definite therapy, has grade 2A recommendation in patients who have in-stent restenosis. If you look at the atherectomy devices as a definitive therapy, it's pretty much all class 3. But they can be used as an adjunctive therapy, not as a primary therapy, most of these atherectomy devices. And again, I will touch upon it very briefly. These are a couple of slides. Again, atherectomy data is not a lot of data available, and atherectomy is really standalone therapy, as I said. CLI data generally, and specifically atherectomy data, less consistent endpoints, making data difficult to interpret. Again, just like in the coronaries, we use it as adjunct therapy, not as the primary therapy. Again, below the knee disease, we talk about the FEMPOP disease. We can use drug-coated balloon or drug-eluting stent. But in below the knee disease, none of these drug-coated devices have shown any benefit so far, and we are still doing the plain old angioplasty. And there are some randomized trials where they looked at atherectomy and drug-coated balloon versus angioplasty. Again, at 1 year, there was not a significant difference between the two groups. There was another trial on paclitaxel-coated balloon angioplasty versus drug-eluting stent for the treatment of infrapopliteal long segment disease. Again, in terms of binary restenosis and patency, there was not a difference. So below the knee, we still, the only option we have is balloon angioplasties. Going on atherectomy devices, I mean, it all depends which device to use as an adjunctive therapy. Again, not a very solid data, but if we see a lot of calcified lesion or a thick fibrous tissue which we cannot dilate, we have multiple devices available, and these are directional, excisional, rotational, orbital. If you have heavily calcified, laser, then we have debulking device, modifying, and combined jet stream or Rotarex. Again, I will be skipping through a lot of these slides, and the only reason I put these slides because this material will be available for you guys to review, but for the sake of time, we'll be flying through it. So again, we have these laser devices. As I said, there is some data in in-stent restenosis. So contact atherectomy, there's suction if you have thrombus. So just briefly on IVL therapy. It's a new kid in the block. Well, not anymore, it's been here for a couple of years now. There is this randomized controlled trial comparing the outcomes between IVL versus balloon angioplasty followed by drug-coated therapy. And what they saw, it was in the interim analysis, midterm outcome data, and what they saw was that the patency, those patients who have IVL therapy followed by drug-coated balloon or stent, their patency was better than those patients who just underwent balloon angioplasty followed by drug-coated devices, as you can see in these graphs. The intravascular ultrasound, again, just this one slide, this was another randomized control trial looking at angiographic guidance versus intravascular ultrasound guided therapy of FEMPOP disease. There was significant reduction of binary restenosis at 12 months follow-up in those patients who had IVUS guided intervention. And based on the Viva consensus guideline, the IVUS should be used. It's mostly appropriate in iliac, mainly appropriate in FEPOP, and always appropriate in tibial disease. And this is something that we tend to underuse not only in the peripheral, but also in the coronaries. But the data is all there. Why? Because it helps us better lesion characterization, better stent optimization, better dissection detection, and improve freedom from repeat intervention. And also, there are studies after studies which shows the IVUS use reduces the contrast use. Again, in these patients with a CLI, most of them, they don't have normal kidneys. Remember, again, it's a systemic disease. So again, this is a great tool to have. Then the last resort, despite you do everything, balloon angioplasty, patient come back, and if you don't have any more option in these patients, and if you have a desert foot, there is no distal targets for bypass surgery or stenting, this is the last resort called the deep venous arterialization. It's fully percutaneous, and what we do is that we go into the vein, the tibial veins, and then we puncture back into the artery, and we connect the artery to the vein, and we create this kind of artificial fistula. And this is one of the last resort therapy that is being performed for a patient who has end-stage CLI with no other options. So this is another case, 82 years old, male with history of hypertension, CKD, and diabetes, non-healing ulcer in the right dorsum, painful, cooler extremities. Again, just based on physical examination, once you get their shoes and socks off, you can pretty much diagnose if someone has PAD or not. Again, started with a small bunion, but we know just on exam, if I don't treat it, a month later, he will be coming back with an open wound. So we did a CO2 angiogram. His creatinine was 1.6, 1.7. Again, you can beautifully see the common femoral artery bifurcation on the right side. And right here, and this is where the distal occlusion was. But you know, as you see, there's a lot of, whenever we tried to cross it from above, the wire kept on going, a lot of collaterals here. So what we did in this patient, there is always an option of retro. We went into the pedal and got the access in the tibial arteries and actually went back all the way, and was easy to cross a lesion from retrograde access, and we were able to do endovascular. Right under the table, you can now see the difference between the right and the left leg, the color. And again, this on left leg also had a lot of complete occlusion, and then we ended up bringing him back in a couple of weeks to fix this. This was another lady, 58 years old lady. It was right after my fellowship back in 2014. She developed severe right lower extremity pain and ulcers after her knee surgery. Her surgery was performed a couple of weeks ago, and she presented with this. Just based on examination, you can see punched out, very dry wound, resting pain. You see this is arterial. And then she had this sensillase test, which was severely, or skin perfusion test, which was severely abnormal. So we performed an angiogram in this patient. As you can see, pretty normal vessels here, but there's a very poor flow down below the knee joint. We could not see really well what was going, because this was a new knee implant. And we did some lateral views, and you can see the complete occlusion of the popliteal artery. And this shut down right after surgery. And she's very lucky that, you know, there is about 1% or less risk of popliteal arterial injury during knee surgery. And most of these patients, they end up losing their legs. So she kind of survived for the next 3-4 weeks. She found some collaterals. But again, this was a static shot. You can see the complete occlusion. And then we did the same thing. We could not cross it from above. We went from below, did just the balloon angioplasty. I didn't want to put a stent in that location, metal, right after metal. But again, because of the vascular surgery, I was not satisfied, because there is a vascular injury aspect of it, right? So I was worried that she might re-occlude this vessel. So an hour later, I did the ultrasound, so the vessel was occluded again. So at that time, we called our vascular surgeon. So this was the the flow right after we performed our angioplasty. You could see the blood flow now. But this re-occluded in 1 hour, so we called the vascular surgeon. She had a limited bypass surgery. So again, it's a teamwork. It should not be about anyone's ego. It should be about the patient. Of course, in the U.S., when this happens, the patient goes on and sues everyone in the hospital. But fortunately, when you document everything, you are safe. And actually, I saved her leg. So this is a 79 years old. Again, last case, hypertension. Again, CKD, creatinine 1.8. We don't want to use a lot of contrast. Critical limb ischemia. So this was the wound, right? And as you can see that it's most likely you have to look at which angiosome or which artery you want to go after based on angiosome concept, right? So you have to, whenever you see this, you kind of already know that which artery is occluded, anterior tibial, posterior tibial, or all of them. Again, you should not be opening everything in one go, especially if someone has, CKD. So this is the CO2 angiogram. We saved some contrast, and then we used some limited contrast below the knee. And as you can see, if you look at the initial anterior tibial, posterior tibial looks all fine, but if you go to the ankle, here, this posterior tibial is occluded. And if you go back to the angiosome concept where the wound was, that area is supplied by posterior tibial. And this is what we did. We went after the posterior tibial occlusion. We were able to fix it and got the flow all the way to the pedal loop. So, and this was, she had limited wound debridement, and this is what the blood flow we want to see, because a lot of people say, well, the wound is already there, so the thing is you want to restore the blood flow whenever, if later on, if the surgeon does the surgery, you have to have good blood flow to heal that stump. And again, in my take-home message here is that CLI team, it's not a one-man job. You have, it takes a village to save the leg. There has to be good communication between your primary care and wound specialist, ID specialist, nephrologist, your non-invasive imaging folks, and then ultimately us. So again, no one is better than the other. It takes a village to take care of these patients. Thank you.